get started. All right. So hi everyone, thank you all for joining us today and welcome to this webinar, COVID-19 and Evidence-Based Programs, Digitally Reaching Underserved Populations. The Society for Public Health Education is an inclusive organization of health professionals. We welcome you as your whole self. My name is Sana Sadiq, and I will be today's webinar moderator. I am the Office and Project Associate at the Society for Public Health Education, or SOPHE. On behalf of SOPHE, we are pleased with the interest in today's webinar, and we are so thankful that you have taken the time out of your day to participate today. Joining me today as the discussion moderator for the panel is Autumn Campbell. After most recently serving as Senior Director of Public Policy and Advocacy at the National Association of Area Agencies on Aging, Autumn launched Due West Strategies in September 2020. In this effort, she aims to advance advocacy, policy, and development efforts for mission-driven but often resource-limited nonprofits and advocacy organizations. At Due West Strategies, Autumn is serving as the Interim Executive Director for the Evidence-Based Leadership Collaborative, or EBLC, a nonprofit organization committed to simplifying the process of selecting, adopting, implementing, and sustaining multiple evidence-based self-management and health promotion programs that promote health and wellness for older Americans and adults with disabilities and community settings. Before I hand it over to the speakers today, I would first like to cover some housekeeping items. First, please note that all attendees are muted for the duration of today's webinar. Please utilize the chat box to interact with the speakers. You will find this chat box at the bottom of your screen. Questions can be submitted at any time during the webinar by typing it in the chat box. After hearing from our presenters, there will also be another Q&A session with the time remaining. For those on the phone, you may dial *9 to raise your hand. This session has live-enabled automatic closed captioning. To add closed captioning, click on the CC button in your Zoom taskbar below to enable subtitles. Feel free to rename yourself if you have not already. You may also use the reactions icon at any time during the presentation. We value your feedback and ask you to complete the feedback survey that is found in the webinar drop-down menu immediately following today's webinar. Your evaluations of this program will assist us in planning future webinars. Please note that today's webinar is being recorded and will be available and archived on SOPHE's eLearn at Core, the Center for Online Resources in Education, within the next 48 hours. To those watching, you will receive an email from SOPHE to access the recording once it's available. An application has been approved for one entry-level Category 1 Continuing Education Contact Hours, or CACH. This program is designated for Certified Health Education Specialist and/or Master Certified Health Education Specialist, or CHES and MCHES, to receive up to a total of one CECH. For those who choose to apply for continuing education credit, please visit SOPHE's eLearn at Core and sign in with your mysophe.org account. Our next quarterly report is October 1st, and NCHEP will update your transcript by the end of the month. SOPHE's mission is supporting leaders in health education and promotion to advance health equity in communities across the globe. Members include health education professionals and students throughout the United States and internationally. The organization promotes healthy behaviors, healthy communities, and healthy environments through its membership, its network of local chapters, and its numerous partnerships with other organizations. The 2021 Virtual Advocacy Summit is now open for registration. Be sure to utilize early bird registration to save on registration fees. Early bird pricing will end on September 13th. Thank you for helping us spread the word, and we encourage you to take a picture of the QR code or visit the Sophie's website for additional information. And now, I'm excited to introduce the 4 speakers you will hear from in today's webinar. The first speaker you'll be hearing from is Paige Jennison. Paige has worked in the field of older adult physical activity for 18 years and currently oversees the Health and Wellness Department at Sound Generations, a multi-service community-based organization located in Seattle, Washington. Additionally, she is the National Director for Project Enhance. In this role, she was responsible for managing the research coordination, business development, local implementation, and national dissemination of the evidence-based Enhanced Fitness and Enhanced Wellness programs. Paige currently serves as the chair of the Evidence-Based Leadership Council. Next, speaking on behalf of the Fit and Strong program, we'll hear from Dr. Susan Hughes and Andrew Demock. Dr. Hughes directs the Center for Research on Health and Aging at the University of Illinois at Chicago and serves as the principal investigator of its National Institute on Aging Midwest Worrell Center for Health Promotion and Translation. She designed Fit and Strong, which is an evidence-based physical activity and behavior change program for older adults with lower extremity osteoarthritis. Fit and Strong has been approved by the Administration on Community Living as a falls prevention program and a self-management adjunct. The program is also recommended by the Centers for Disease Control and Prevention as an arthritis-appropriate evidence-based lifestyle intervention. Andrew Demock coordinates the Center for Research on Health and Aging at the University of Illinois at Chicago and manages the nationally recognized evidence-based program Fit and Strong. He received his MPH in Community Health Sciences from the University of Chicago School of Public Health. And finally, we'll hear from Nick Turcos, who as a nonprofit professional for more than 20 years has successfully designed and managed local, regional, and national programs and services with measurable results. He currently oversees the Walk with Ease program and manages relationships with national nonprofits, academic institutions, and healthcare professional societies. Nick earned a bachelor's degree in public relations and a master's degree in human services management. I will now hand it over to Autumn, who will introduce the programs we will hear more about today.
Great. Well, thank you, Sana, and thank you, Sophie, and to our speakers for joining us today. So I will be moderating the discussion, and we really hope that this will be an open discussion. So we certainly encourage you to leave questions in the chat throughout the discussion, and we'll try to address some of those questions and comments as we go along. And we'll also leave ample time at the end for any final questions and discussion. So before I get started, though, in moderating that discussion, I do want to offer a brief overview of the Evidence-Based Leadership Collaborative, as well as the programs that we'll hear about today. So the Evidence-Based Leadership Collaborative, or EBLC, is a long-standing collaborative effort aimed at increasing access to and helping stakeholders adopt and implement evidence-based health promotion programs. EBLC offers connection for communities and organizations seeking to learn more about innovative programs proven to help people manage and improve their health and well-being. Additionally, and increasingly, EBLC aims to ensure that policy at all levels supports evidence-based program implementation. And that goes across community-based funding for the programs, and even as programs are incorporated into the services and supports that healthcare payers offer. EBLC as an organization also provides technical assistance and resources to individual programs and community-based organizations that deliver these programs, and is focused on enhancing sustainability of more than 2,000 evidence-based programs offered in communities across the country, which, as we know, and many of us have experienced, is even more important as we grapple with many of the permanent paradigm shifts to health and community-based supports, particularly for high-risk and hard-to-reach communities that we've seen during COVID and beyond. Now, there's one important distinction I want to leave you all with before I continue, is that research-based does not equal evidence-based. A common misperception is that programs that have been based on research can then be considered evidence-based. However, many research-based programs do not actually fit that definition of an evidence-based program, as stated, as Sana stated and talked about earlier, and will continue to talk about throughout the program. So just because a program contains research-based content and programming, or was guided and developed by research, doesn't mean that that program itself has been proven effective. So unless that program has been tested and shown to be effective, it is not actually considered to be evidence-based. Next slide, please. So while evidence-based programs are programs that have been rigorously tested in controlled settings and proven effective and translated into practical models, it's also important to note that the programs and the evaluations of those programs themselves have been subjected to critical peer review from other experts. Ultimately, in implementing evidence-based programs, there is certainly there is certainty that the program works, and it's highly likely to improve the health of participants and constituents. So ultimately, implementing an evidence-based program is widely considered a best practice strategy for community health promotion. Evidence-based programs that you'll hear about today, as well as the panoply of evidence-based programs that EBLC works with and represents, are proven to positively impact the health of program participants. They're also beneficial in that funders of these programs can meet those demands that programming be based on solid evidence. Often agency leaders also that of the agencies that are deploying evidence-based programs in communities want to ensure that they're concentrating limited resources in those communities on evidence-based programs. Participants of evidence-based programs can also guarantee that their time is invested in programs that have been proven to work and that they're not wasting their valuable time. And also the demonstrated outcomes of evidence-based programs are often attractive to community members and other partners. Again, so that's what makes these programs unique, and where the Evidence-Based Leadership Collaborative can offer a lot of value in helping connect you and your organizations to evidence-based programs. Next slide, please. So all the programs that you'll hear about today are considered evidence-based, and they have a robust portfolio of proven efficacy, pardon me. Specifically, EBLC's directors have been involved in the development, implementation, evaluation, and scaling of programs addressing chronic disease and medication management, falls management and physical activity to increase awareness of and provide interventions to prevent falls, a lot of those you'll hear about today, and improve physical health and well-being, which you'll also hear about, as well as identifying and addressing the underlying symptoms of depression in older adults. So as you will hear from speakers today, achieving those and other goals during the COVID-19 pandemic has forced many of these programs to dramatically re-envision delivery methods while maintaining the integrity of these programs. So we appreciate the support of Sophie and other partners who are supporting EBLC leaders as they conduct evaluations to assess program efficacy via remote and digital delivery methods, including bolstering the capacity of the paid and volunteer workforce that ensures program deployment in communities. Next slide, please. So if you'd like to find out more about evidence-based programs, I encourage you to check out any of these resources, and we'll also put up some additional resources at the end of this presentation. Next slide. Okay, so quickly here. Programs that you will hear about today represent a broad array of evidence-based programs that are proven to improve the quality of life in adults with arthritis. You'll hear from developers and directors of these CDC-recognized arthritis-appropriate evidence-based interventions, regarding distance-based training practices developed during and in response to the COVID-19 pandemic, and the challenges and opportunities inherent in these strategies to expand the evidence-based program workforce and to reach rural and underserved communities. So there's a lot of ground that we're covering today. But again, we want this to be an open discussion. So please continue to put your thoughts in the chat, and we'll try to respond as real time as we can. Specifically, we'll hear today from the leaders and teams representing Project Enhance, including Enhance Fitness and Enhance Wellness, Fit and Strong, and Walk with Ease. But before we jump into the specific topics for discussion, I'm going to provide a high-level overview of each of these programs. However, I will certainly defer to our speakers and our subject matter experts today to provide important additional context and add color to what makes their programs tick at a community level. Next slide, please. So first, we'll hear from our team at Sound Generations, and Sound Generations oversees both Enhance Fitness and Enhance Wellness. Sound Generations is a multi-service nonprofit organization that has worked to meet the physical, emotional, and social needs of aging King County, Washington residents since 1967. Their mission overall is to support people on their aging journey through community connections and accessible services. And they strive to expand beyond the provision of food security, transportation, health promotion programs, and assistance services to underserved populations regionally and beyond. Today's focus will be on 2 Project Enhanced programs, which Sound Generations oversees nationally, with support from their scientific advisory partners at the University of Washington. Enhanced Fitness is a low-cost, evidence-based group exercise and falls prevention program that helps older adults at all levels and fitness levels become more active, energized, engaged, and empowered to sustain independent lives. Enhanced Fitness consists of group exercise that meets regularly and focuses on strategies for adults or people with disabilities who have limited mobility. Enhanced Fitness also incorporates cardiovascular exercise, strength training, balance, and flexibility, which we can certainly all use regardless of our age or ability status. Next slide, please. Enhanced Wellness, which is also part of Project Enhance, overseen nationally by Sound Generations, is a one-on-one health management program. So it takes a different tact, and it's designed specifically for older adults with multiple chronic conditions and those aging with disability. So instead of a group setting, Enhanced Wellness takes an individual approach by connecting participants with a personal health and wellness coach and focusing not only on physical, but also emotional and social well-being. Enhanced Wellness uses screening, planning, and action and accountability strategies to accomplish program goals, but it also integrates with other health promotion programs, groups, and resources. Next slide, please. So moving on from the Project Enhance, we will hear from Fit and Strong, which is an award-winning, multi-component, evidence-based physical activity program for older adults. I know Sana went into some of these details earlier. This is an 8-week program that targets older adults with osteoarthritis and has demonstrated significant functional and physical activity improvements in this population. In addition to physical activity, Fit and Strong incorporates education and behavior modification strategies for participants and is especially targeted toward adults with pain, stiffness, and arthritis symptoms in their lower extremities. Next slide, please. Now, Walk with Ease is developed by the Thurston Arthritis Research Center and the Institute on Aging at the University of North Carolina. So we're moving east across the country here. The Walk with Ease program can be experienced individually or with a group. So the 6-week Walk with Ease program focuses on educating participants about how to make physical activity a part of their everyday life. The program includes a guidebook and a walking schedule to get participants safely moving toward better health if they're doing the program individually. Both group and self-directed formats are available. The groups meet 3 times a week for 6 weeks, and trained group exercise leaders begin each session with a pre-walk discussion covering a specified topic related to exercise and arthritis, followed by a 10 to 40-minute walk. The self-directed program includes a guidebook to help participants develop a plan, stay motivated, manage pain, and exercise safely. So next slide, please. So before we get started today, we've got a couple of questions that we're hoping that we'll get some engagement from you all, just so we have a sense about who's joining us today and the particular perspective and interest level of the audience in these programs. So the first question, if you could tell us, is what kind of agency do you work with? Thank you all for weighing in here. Okay, great. So it looks like we have a diverse crowd with us here today, primarily representing federal government agencies, nonprofit and community-based organizations, a couple folks from state and local health departments, healthcare organizations, and a couple folks joining us from higher education institutes or other. So Thank you so much for that. And Jordan, I'm happy to defer to you or Sana if you have anything more to add there.
This is wonderful, Autumn. Happy to see who's in the room and share more content specifically tailored to you. So move on to the next.
Great. So the next question here is, who is currently delivering or referring to evidence-based programs as an integrated part of their work to improve health outcomes? Maybe we have a couple more here. Okay, great. So the bulk of folks are currently delivering or referring to evidence-based programs as part of your work. Hopefully those who are not, we can certainly answer some questions and provide some proven value in these programs, as well as provide additional context for those of you who are unsure. So thank you so much for that input. And I'm certainly happy to move on, unless again, Sana or Jordan, the team at Sophie has anything else that they'd like to add before we move on to the panel discussion.
Yeah, I think it's great that we have a good portion of our audience, directly either delivering or really referring to these evidence-based programs, because as we move into this age, or we have been into this age of remote delivery and seeing how that looks different with every sort of organization and is very dependent on the needs of populations. I think that there's a lot of great conversations to be had. Great.
Well, thank you, Sana. So let's go ahead and get started with our panel questions. So question one, describe how you moved in-person programs to remote delivery, such as remote formats, some of the considerations and the barriers to doing that, some of the opportunities with remote delivery. I'm happy to start. Let's start with Paige with sound generations. So I'm going to go ahead and defer to Paige to get us kicked off here on this conversation.
Thanks so much, Autumn, and it's wonderful to be here today, and thank you to Sophie for hosting and to EBLC for moderating today's panel. I'm excited to see folks from a variety of organizations in the room that will be sharing their knowledge, and I'm sure some really good questions to get us all thinking together. And that's really what we've been doing over the last year and a half, right? So how have you moved in-person programs to remote delivery? Well, Project Enhance is comprised of two programs, and I'm going to start with Enhance Wellness. And maybe a little bit of an odd place to start because we didn't have to adjust it to move to remote delivery. But I did want to just say something about that and really apply a health equity lens as we review these questions and think about our responses to them. So Enhanced Wellness is a chronic disease self-management program, one-on-one health coaching, as Autumn shared. And at the request of the disability community in the one of the NIDLR-funded studies with that program, adaptation was requested by the disability in the community trials to shift the program all to phone delivery. So there was the opportunity to test and to understand the efficacy, which matched the in-person and multi-mode efficacy of that program, and no changes were needed. And I keep coming back to this time and time again in conversations because I just think it's really important to call out the fact that when we meet the needs of communities that may seem a little more difficult to reach, it works for everybody. So Enhanced Wellness was one of the programs that didn't need to pause during COVID. However, when we think about the opportunities and considerations, really additional focus was needed for engagement and really understanding for those that had not been delivering all by phone, how best to engage people that they weren't meeting in person, and build that rapport. So we can certainly go into more there. But for the broad swath of evidence-based programs, certainly long established program models that have been in person delivered were paused and needed to be adapted to reach increasingly deconditioned older adults at growing risk for falls and other consequences of isolation and loneliness and decreased mobilization. So with the Enhanced Fitness program, we have really benefited from a strong collaborative spirit with program administrators, including those on the call today, funders, research partners, certainly, and community-based organizations and participants to reach more people with these proven programs. So what we did, we had a NIH-funded study in process at the time physical distancing guidelines were put into place by local health jurisdictions, and they reached out, went through all the IRB approval, all the I's were dotted and the T's were crossed, and the folks at University of Washington actually helped us build a container for remotely delivering enhanced fitness and understand what that looks like within a research setting. So we were fortunate to have their support and to be able to do that. We took that tested, piloted work that was in process, understanding what was going on. And at the same time, we started conversations with some of our large delivery partners, including the Y of USA, which has a national license for the Enhanced Fitness program, the National Kidney Foundation of Michigan, which delivers enhanced fitness through a wide number of types of organizations throughout Michigan, and then as well as an area agency on aging, Elder Services of Merrimack Valley in the Massachusetts area that works with across really 6 states up there with evidence-based programming, and the Y Mass Alliance. And together we translated what was happening in a research setting to guidance that would be practical on the ground to happen within a community-based organization that, you know, maybe didn't have funding already set up for devices or for navigating some of the digital questions that have been explored through this time of innovation. So we really worked with them. This resulted in issuing national guidance in September of 2020, and then hybrid guidance, which we can talk about more, that was issued in May of 2021. So what did that guidance look like? Largely, enhanced fitness was remotely delivered on a two-way interactive platform. A lot of it was on Zoom. A lot of it was happening on WebEx and other platforms with no changes to the workout. One of the additions to the workout was a zero session or an informative session to do baseline fitness assessment, you know, to understand where people were, to help them with any enrollment questions, as well as navigating technology. So those kinds of interactions happened within the zero session that is added to Enhanced Fitness remotely delivered. And then key new safety measures were put into place. We already had a lot of safety measures in person that we just needed to understand how to navigate with in a remote setting, but we also added a technology support assistant that is there in every class in addition to the Enhanced Fitness instructor. And there are eyes and ears for the program, but they also help with those digital questions, which we know tail off after a couple of weeks, but in the beginning, there's quite a few. So that's been a really important consideration for safety. As part of that safety with the technology assistant, the emergency contact, location information. We know what's going on at the beginning of every class, and that's now checked, which is also a new thing for us. And the class size is decreased. Many of you are looking at this Zoom on a laptop like I am today. It's a lot of little boxes. 25 of those little boxes are just, it's too many for us in a class right now. So 12 is the maximum number for a class site right now. And that's with the technology assistant on there as well. So those are some of the things that are going on with enhanced fitness, remote adaptation. And I saw Sue Hughes, I think probably nodding to relate with Fit and Strong as well. So I'm going to hand it over to Fit and Strong to talk a little more.
Thanks so much. And Drew is going to take it away.
Yeah, thanks so much, Paige. I'm Drew Demock, working with the Fit and Strong program. There's definitely a lot of overlap, and we're going to echo a lot of what Paige just said. But starting in March of last year, we asked all of our providers to stop offering in-person Fit and Strong programs in classes. All of our classes are typically offered in groups. We quickly realized that COVID would be overstaying its welcome and not going away anytime soon. And from there, we shifted to working closely with our provider network to develop what we call Fit and Strong at Home, which is a completely virtual version of the Fit and Strong program. As Paige said, we offer our class in a similar format. We use Zoom or similar software. The classes are performed live, and the content is exactly the same as the in-person classes. We knew that offering it live would be key. We know that a lot of Fit and Strong participants are frail, some are at a high risk for falls, and we really felt that live was the only solution. This offering it live allows the instructors to monitor the participants in real time, so they can make sure that they're doing things safely. They can provide feedback immediately. They can make sure that their home workout space is set up safely and correctly. And it also retains the social aspect of the program, which we know is so important for a lot of the participants. Also echoing what Paige said, we do have pre-class sessions that we advise the providers to offer. We suggest these even in an in-person class. We've expanded them a little bit for the virtual version because we know that there's a bit of a technology learning curve. So during these pre-class sessions, the instructors work with the participants to just make sure that they can understand the mechanics of Zoom or WebEx or whatever platform that they're using, and that they can make sure that their workout space is correct, and set up safely, and just prepare them to start the class, learn how to be on camera, learn how to mute. And what we have found is that even with participants that aren't quite familiar with the technology, after the first handful of classes, generally they pick up what they need to learn to participate in the class, and technology doesn't become much of a barrier, an issue after that point. And we designed it in a way to try to make technology as minimal of a barrier as possible. Participants just need a free account for whatever platform is being used, and they just need any kind of internet connected device to join. So it could be a laptop, a tablet, a phone, whichever. And as an additional resource for the providers, we've created a Fit and Strong at Home website, not just for providers, but participants can also use it. And this website has all of the resources and essentially everything that's needed to conduct the program in one space, with everything at everyone's fingertips. So the instructors can launch the classes directly from the website. They can embed the Zoom links so everybody can access them and begin classes from there. There's exercise demo videos that instructors can share on the screen with the participants. The health education manual is on there in a digital version. So the lesson plans for the class that day can be shared on the screen. We also have an FAQ section for instructors and an interactive wiki that instructors can contribute to. So if they have a tip they want to share or something helpful, they can plug it in directly to the website and share it with the network of instructors. We also have participant resources on the website. So all the paperwork, lesson plans, homework, and additional resources are available to participants even after the class is over. And we were able to embed the data collection piece directly into the website. So instructors can enter attendance right to the website. The pre and post outcome survey is there for the participants. And the instructors can meet with the participants to help walk them through it as needed. And there's evaluations for the participants and instructors that they complete at the end of each class. This remote version has also lent itself to fidelity. Fidelity checks it's pretty easy for us to perform them. And we do that by either joining a class and watching from the background or asking our provider to record a session and share it with us. And we review it and get back to them with feedback. Yeah, so that's an overview of our virtual version of it. We have found that it's working quite well. Also echoing what Paige said, we've come up with guidance for a hybrid offering. I think we're all on the same page when we say hybrid. What we're referring to is a class offering where you have participants that are attending in person, but also some attending virtually, so connecting to the class online. And even after COVID is over, we think the virtual version and the hybrid version are always going to be, there's always going to be a need for them. And there's some providers that are going to rely on them, especially in areas like rural areas where it's difficult to get people in person.
Great,
So, yeah.
Thank you so much, Drew. I know both you and Paige have raised a number of important points, particularly regarding safety, technology, data collection, program integrity, and I will turn it over to Nick now to add any thoughts he has on this particular question.
Thank you, Autumn. Thank you so much, and thanks again to Sophie and to the our program partners that are presenting on this call today. As I talk about ways that we have moved our programs to a remote delivery, I think it's just really important to mention how important that is to increase our reach as evidence-based programs. The evidence-based programs are effective, but they still reach a small fraction of the number of people that we need to reach. And so by innovating with our programming and using this crisis that became an opportunity, hopefully we'll be able to grow these programs even more without sacrificing any of the quality that the programs have. And much like my colleagues on this call today, the Arthritis Foundation did pivot to provide additional opportunities for program engagement. So the Walk with Ease program, as we've mentioned, is this community-based physical activity program with self-management, with stretching and strengthening exercises, with goal setting. And it's always had 3 formats to offer the program. So our traditional group program with a trained leader in front of a class with a group of people that goes through that class 3 times a week for 6 weeks, traditional programming. And we've always had this self-directed model where a program partner could offer the Walk with Ease guidebook to a participant, and that participant would commit to completing the program on their own. They're going to read the book, they're going to walk at least 3 times per week, and they're going to complete their goal setting and their fit tests and complete the program. And we've had research for almost 2 decades that shows that if you do this, if you actually do the program, the results, the benefits for the self-directed program are just as good as the group program. And that's really hard, even for me to believe sometimes, because we're so committed to group programs. But the program is designed to be simple and effective, and it really does work if you work it. And we have been working with this self-directed model over time, in particularly with our work force model. So we have been working to get this Walk with Ease program in work sites. And we did a pilot project, and we worked with a lot of large employers, and we said, we want you to do this program. And they all said, we want to do group. And they started hosting group classes. And about halfway through the program, we started getting all these emails. Oh my gosh, 3 times a week, every week, 3 times a week. We didn't realize that not only we were going to be leading the classes, but we had to do some prep before. We've got some administration work with attendance and surveys, just the program administration. Just any program developer knows that that's part of the model. And they said, there's got to be an easier way to do this. And we said, self-directed. You can give people the books and they can do it on their own. And they said, I don't know that, well, how do we know that they're really going to do it, right? And so we've been working on the self-directed enhanced model. So self-directed enhanced is a way for a group of individuals sign up at the same time. You create a cohort of participants, and every week you provide them with a minimum of 1 communication per week. And that communication reminds them, hey, you're in this class. This is your reading. Remember to do your walking. And it will provide opportunities for those individuals for additional engagement, totally voluntary, but you could say things like, hey, if you're doing your walking this week, we're going to be meeting at the flagpole at 9 a.m. Monday, Wednesday, Friday. Come join us. Those folks are walking individually together. Well, COVID hits, and we are working with our CDC partners. We're working with organizations. They're all doing group, because that's the format that everybody feels most comfortable with. And they're saying, we've got grants. We need to fulfill these programs. What do we do? And we talk about self-directed, same sort of hesitancy. Self-directed enhanced becomes the #1 way to deliver this program. And we created a toolkit, a self-directed enhanced toolkit, that really walks organizations through the process of signing everybody up, how to get them a book. You can get them a physical book, but we also have an ebook that you can get through Kindle. So that makes distribution of books a lot easier. Even talking about a hub and spoke model where you could have a pickup day at your organization where everybody picks up their book, and then maybe during a time slot, and then they do the program the rest on their own. So we've created this model for signing people up. And then we also made it a lot easier for them to deliver the programs, because we worked with some of our partners that had been doing self-directed enhanced, and they had developed a cadence of emails or communication that they could share with the participants. And so we made that communication available in the toolkit. And so now folks aren't recreating that communication every single time. So we make it easy to sign people up, to deliver the class, to deliver the materials, and do the program in a way that we know has been proven. So that is the main way that we have taken our Walk with Ease program that was always available in those 3 formats, but really sort of put gasoline on the self-directed enhanced program. Thank you.
Great, thanks. And Paige, did you have a comment that you wanted to say in response to Nick's comments?
I did. I just wanted to support what Nick was saying, and Drew mentioned as well about, the results we're seeing from these remotely delivered programs. Both Drew and Nick talked about the importance of the integrity of the model, and just really strong, focus on making sure, we're still doing the things that keep the program proven, and just making those simpler to access. And, when I spoke a little bit about the enhanced fitness program and our opportunity as it happened to have researchers on the ground to help us build the container, I did want to share a little bit about program efficacy. And and what we were seeing from that in terms of, 87% attendance rate, so really strong program adherence, no dropouts, no safety events. At 16 weeks measurement, which is our standard unit of measurement, improved self-reported knee physical functioning and quality of life, decreased pain interference with their physical functioning, as well as with that research component, being able to see measured heart rate, that they're getting a moderate intensity workout, and grab information, evaluation information to really understand. I mean, it's great if a program works. If people don't want to do it, it doesn't help them. So seeing that 95.5% of participants reporting satisfaction with the model, and saying that, on a scale of 0 to 10, say a 9.1 on, did this help me get more physically active? And I think those are such important things to call out about all of these programs that we're talking about today, even though that specific data is from Enhanced Fitness Pilot. So just backing up what my colleagues are saying. Back to you.
Great, thank you, Paige. I have a quick question before we move on to question 2. Did any of you find program participants who didn't have cameras or were hesitant to do exercise and fitness-based programs with their cameras on? And if so, how did you address that?
I can jump in for Fit and Strong. From what we're hearing from our providers, the issue hasn't been so much that people, aren't comfortable on camera. It seems like people are really actually liking the visual and, the social piece that goes along with that. It really is just a matter of having access to the technology. That continues to be a barrier with some organizations, is getting seniors access to the technology and then getting them familiar with it. Luckily, we've been able to work with some AAAs that have CARES Act funding that have used it to purchase things like tablets with an internet subscription. They can lend it to the older adult participants, and they're able to participate that way.
Great, thank you, Drew. And I see a question here from a participant about measuring the social and mental health among remote program delivery. Is that something you are, any of you are working on or toward? I know some of these evaluation efforts are still underway.
Well, I could mention that the Arthritis Foundation has been doing a patient-reported outcome survey for all people with arthritis. So this isn't evidence-based program specific, but we have a data set of 40,000 plus participants in this survey, and we asked people to talk about their physical health, their mental health, and their access to care. And under mental health, that I was not surprised to see a high rate of depression listed, but also anxiety was very high on the list. So more than a third would mention that they had symptoms of anxiety over the past 2 weeks. And so although I don't have specific data on evidence-based programs, I think it is very important to mention that mental health is a major stress point for people living with joint pain and chronic disease, and it's something we should be very aware of.
Thank you, Nick. I think that's a good point at which to pivot to our next discussion question. And please keep the questions coming in the chat. Our speakers, as they are able, are reviewing those questions as well, and I know can respond directly when appropriate, and we can certainly follow up if we don't get to all of them today. But I'm glad we have some extra time together today. So question number 2, describe how you're reaching underserved populations with remote evidence-based programs. And I know that underserved populations can mean a lot of things, but specifically communities of color, rural communities where broadband and other technology access may be very limited, and communities of people who are living with disabilities. So I'm actually going to turn this over to Nick to start us off on this particular question.
Thank you for the opportunity to speak to this. And so first things first, I want to be very honest and very clear that although the Arthritis Foundation is deeply committed to reaching everyone with arthritis, we are not doing enough. We're not. So I don't want to come up here and say that we are an expert and that we've got this figured out. We don't. And this will always be a process because as arthritis evolves, people evolve, and there are always going to be different needs for people. And I think as our program, we just need to be always aware that we need to do more to find people to reach the 54 million people living with arthritis. So number one. So what are we doing? So first of all, the Arthritis Foundation's Walk with Ease program is available in 2 languages. So it is available in English and in Spanish. We do have a separate participant guidebook called Camino con Gusto that is available for purchase on our website alongside the English version of the book. The program is available as a self-directed program only. So with Camino con Gusto, we do not have a leader training program. So I want to be honest about that. So other ways that we're reaching underserved communities is largely through our national partners, our healthcare provider partners, and our state partners, and our field team. So we really go after this a couple of different ways. So as part of the CDC recommended programs, we are often on technical assistance calls with other organizations to talk about how the program works, the benefits, and technical assistance. And I know that I have been on dozens of calls with Andrew and Paige, talking with other groups about how to reach other people and how our programs can be innovated and to reach these communities. So it's something that we're always doing together and we're always available to do. We're working with our friends at National Association of Chronic Disease Directors, National Recreation and Parks Association, YMC of the USA, the OA Action Alliance, the Osteoarthritis Action Alliance, which is part of the UNC Chapel Hill. They have actually developed a portal that helps deliver that self-directed model. So if you are an organization that wants to sign folks up to participate in the Walk with Ease program and need assistance with delivering that communication, tracking outcomes, this new portal that they have will really make things a lot easier for you. And so it's a great service. We do work with extension offices. There are a number of states like Kansas, New Mexico, Oregon, Washington, Delaware, South Dakota, Minnesota, West Virginia that offer the Walk with Ease program through a variety of those portals through their extension services. We also are working with healthcare provider groups, in particular Baylor Scott and White, which is one of the largest healthcare systems in the state of Texas. They have committed to using Walk with Ease in their health and wellness program that serves African Americans and Hispanics. We work with influencers like Dr. Tamara Huff, who's known as the Lady Bone Doc, who features the Walk with Ease program and the Walk with Ease portal on her website. The American Physical Therapy Associates have lots of information about Walk with Ease and how they endorse the program on their website. And then lastly, I will also say that the federal prison system has adopted Walk with Ease. So the First Step Act selected the Walk with Ease program among many other evidence-based programs. And we have had thousands of participants through the federal prison system have that program reach through that portal. So the last thing I will say is that we have a field staff. We have a field staff and volunteers all across the country. Just about every metro market across this country has an Arthritis Foundation staff member or a volunteer that really serves as a leader for their community, for the arthritis population. And those staff and volunteers reach into the community with their AAAs, with their senior centers, with their YMCAs, fitness clubs, schools, and talk about the benefits of the Arthritis Foundation and our evidence-based programs like Walk with Ease. So through all of those channels, we really do hope to reach the largest audience possible. Thank you.
Thank you, Nick. And I'm glad that you brought up the volunteer and staff component, which we will get into in our next discussion question. But I will kick it over to Sue to tell us some of the work that they are doing to reach underserved communities with Fit and Strong.
Thanks, Autumn. I want to also thank Sophie for sponsoring this and to just say how excited I am to be on this panel with all the other members. And I also want to thank people for taking the time out of your days, to attend this webinar. We know how challenging it is, especially now, for people to be out there serving, people with these conditions. So I wanted to basically make 4 points, in my response. And the first one was that, and this is an incredibly important question, it's an important topic, reaching underserved folks. And I agree with Nick's opening salvo that we are not anywhere near where we need to be. And I am so impressed, Nick, with what the Arthritis Foundation and Walk with Ease has achieved so far. The prison work and so on and so forth sounds really, really terrific. So kudos to you. So to get back to what Fit and Strong is doing, basically, our traditional program has done very well with underserved groups. One of the things about our program is that our university is based on the south side of Chicago, or bordering the south side and the west sides. So we have particular, kind of access to these underserved, disadvantaged populations, and it's part of our university's mission to reach out to them. So we have always included those populations in any of the Fit and Strong research, that we have done. So with respect to the at-home version, the at-home version is done well. We basically are doing the program with great success in the Dakotas, which are very much a rural area. We're also had great uptake in low SES, heavily African-American communities like Baltimore and the District of Columbia. So we're really encouraged by that. And one of the things, the second point that I wanted to make, one of the things about the at-home version that I think makes it easy to do is that we have a very low barrier to entry. Anyone with an internet-connected device, a phone, a tablet, or a computer can basically join at no cost. So it's, low barrier to entry. Drew already mentioned the fact that many AAAs in areas where we offer the program are partnering to offer devices and internet access to seniors through the CARES Act. So we're more than happy to provide a link to that, to talk to anybody about that, during this webinar. The third issue I wanted to talk about was disability. We've always been concerned, we target people with lower extremity osteoarthritis who have symptomatic OA. So everybody basically who participates in our program has a disability by definition. But there are degrees of disability, and we have basically taken the at-home version and we've tested it in an assisted living facility. And that was really a fascinating experience because this is a population that is at really, really high risk for falls. So we wanted to be especially, kind of careful and about safety issues. spent a lot of time working with our instructors about modifying the at-home version to start low. Forgive my voice, start low and go slow. Okay, because it was really, really important to give seniors the opportunity to kind of make the mental connections that they needed to make between, kind of hearing an instructor and then moving their body safely in response to the instructions and so on and so forth. So we also, for that type of program, we had the instructors read parts of the manual aloud to make sure that everybody was able to be on the same page, literally, and also understand, kind of what the message was. So the fourth thing is I just wanted to mention that another experience that we have had with people of color is that we were offering Fit and Strong on the south side of Chicago a few years ago, and we did a fidelity check. The enrollees at that time were all basically older African-American women. And they said, we love Fit and Strong, but it doesn't have enough kind of weight management information. We'd like to know how to manage our diet. So we went back to the table and we basically developed a new version of the program called Fit and Strong Plus. So the Plus version includes both physical activity and diet weight management. We tested it in a 5-year randomized trial funded by the National Institute on Aging. We published the findings. The evidence has been approved by the administration on community living, and we are currently looking for people to do the program. So if you're interested, let us know. We want to hear from you. So the amazing thing about that experience is we offered the program on the south side. We had 95% of the participants were African American, and they were all overweight or obese at baseline. And we got an impact on BMI, waist circumference, weight, and clinical measures of their extremity function and strength at 2 months when the program ended that were maintained at 6 and 12 months. So they weren't huge differences, but they were, people did modify what they were doing. And this is a really, really hard to reach, very high risk population at baseline. So we were very encouraged by that. And, if anybody would like more information about it, more than happy to, continue that discussion. So I'm going to be quiet now.
Thank you, Sue. Those were a lot of important points. And just in the interest of time, I will turn it over to Paige, but happy to come back to any of the points that you or other speakers have raised in response to this discussion question.
I love hearing about Fit and Strong Plus, and I'm really excited about that program and thinking too, and tying into my initial comments of how that program and that, it was informed by the community asking for it, right? They know what they need because they're closest to issues, and just really excited about Sue's work there and Drew's in Chicago going on. And in our work at Sound Generations, we offer programs that are accessible to all people with kind of an understanding around, we need to understand the identities and cultures, as Sue was talking about, of the people we serve to be able to deliver health promotion programming effectively. So one of the populations that we have been really focused on for a few years, and it just really, filtered down to a laser focus during this last year and a half, has been people with disabilities. 61 million adults in the US live with disabilities. A third have onset before age 40. And adults or people with disabilities, they're aging with disability, often don't know about these programs that are over here talked about in the older adult sector. Sometimes there's not awareness of that. So, and so physical activity programs like the 3 talked about today are really good examples. And I just want to say a little bit more about that population in that specifically in that, they're 3 times more likely to have heart disease, to have the chronic conditions, to have stroke and diabetes and cancer than people without disabilities. And nearly half of them get no aerobic physical activity at all. So, this is a really important health behavior and one we've really focused in on. Starting with the Enhanced Wellness Program, very specifically, doing work with those 45 years and older, University of Washington Neidler funded study that is now continuing with a Niner funded study delivering enhanced wellness by telephone. The adaptations there from the community are greater flexibility in contact. We talked about it being all telephone based and knowing that works because of the initial trial and now that's being continued. But adding measures, some of the measures that were originally involved in enhanced wellness just didn't resonate for this population. So 3 or 4 additional measures were added that can be tracked. Enhanced wellness is really about what matters to the participant, not what's the matter with the participant. So what do they want to work on? So we heard 4 additional measures that needed to be added that are now available for working with that community specifically. And then by participant option, inclusion of a family caregiver or a attendant in those sessions if they want to have them, which was something unique, having the caregiver participate as well in those one-to-one sessions. Yeah, I see Elaine's question in there, and that's a great question I'm going to be getting to in just a moment as we talk about enhanced fitness as well. We worked with starting in late 2019, so most of our work was done in 2020 during COVID with the Lakeshore Foundation as part of work funded by the National Center for Health, Physical Activity, and Disability to create inclusive practice guidance that would inform our enhanced fitness sites, our enhanced fitness administration, our leaders. And that was published in March of 2021 after a pilot using that guidance happened from November to February of 2021. So the Enhanced Fitness Inclusion Guide is available free to everyone. And it is, you just reach out to projectenhance.org. I think it widely speaks to, very broadly, to physical activity programs, how to improve reach with this population, teaching strategies for different types of disabilities, thinking about exercise modification. So that's one way we've really worked to integrate, accessibility more and more into our program that, like Sue had mentioned, really was created for people with mobility disability or other challenges, but we've kind of worked to level that up. And lastly, I'll just say I'll switch from the disability community very specifically to the rural community. And during COVID here, we've worked with a rural healthcare provider to deliver enhanced fitness remotely to their healthcare population. That's gone very, very well. And now that pilot's complete with strong learnings and strong significant findings, that healthcare provider is self-funding continuance of the program. So, that's the thumbs up we all want to see to grow these programs. As Nick and Sue mentioned, there's just there's a lot more to do, to roll up our sleeves and do. And we're continuing that work now with a federally qualified health center in Wyoming, very rural area, similar model to understand how it goes there. So definitely remote delivery is here to stay, and we are reaching rural populations with this work. I saw Elaine asked a question that I wanted to answer. I'm sure others did.
The question was from Elaine was, are there any programs serving caregivers of persons with dementia? So I'm assuming, go ahead.
Yeah, I'd love to say something there, and then I'm sure the other programs would as well. I know one of our experiences that, this work is hard. We've been doing a lot as program administrators over this last year and a half. And I think something that made us all stop in our tracks and understand really how important it is an organization that we were working with that had a gentleman coming to the class to enhance fitness once a week, most weeks, kind of. We know that doesn't exactly work. Consistent dose is very important for physical activity. Remote delivery was offered. This gentleman signed up for it. He's in the class 3 days a week, consistently. He's always there. And his spouse, who has mild cognitive decline, is in the class with him. And that just, boy, that brought it home at how valuable this class is to reach, and these remote models are to reach populations that have barriers that we need to do quite a bit of work to overcome. So, yeah, so I'm sure Nick and Sue probably have something to share there too, and Drew, but I just wanted to share that.
Go ahead, Sue.
So I just wanted to add, and maybe Drew wants to add to this, we did in the assisted living pilot that we did allow the facility to include people with mild cognitive impairment. The issue did come up. It's common, for, the prevalence of dementia in assisted living facilities. Is pretty high. So this did come up, and when we did not use like the MMSE or the MOCA or anything like that to do a cutoff score, we basically just asked staff to use their judgment about, residents whom they thought might have some mild impairment, but could still benefit from a class. And that seemed to work pretty well.
Great, thank you. Well, I'm going to move us on to the third discussion question, and I think this one really gets to some of the heart of these changing models. These programs, you can't deliver them without the staff and without the volunteers, but obviously when you change the delivery method and mode, there are training gaps that need to be filled as well. So can each of you describe how you're distance training the workforce to build capacity for these programs, particularly to reach underserved populations? And with this, I will actually go to Drew first to kick us off.
Great, thanks, Autumn. Yeah, I wouldn't say fortunate, but Fit and Strong was somewhat prepared. We've had an online asynchronous instructor training for the traditional Fit and Strong program for several years. This was developed as part of a partnership we had with the NRPA. The NRPA is a recipient of a CDC grant to disseminate a few arthritis appropriate evidence-based interventions nationally. And we knew to successfully partner with them on this, we would need to come up with a remote training ability to train people remotely. We were able to secure a small foundational grant to help fund it. And we were also fortunate within our university, we have a department called the College of Medical Distance Education. So this is their wheelhouse. This is what they do, creating these online learning environments we were able to partner with them, and we created a platform for Fit and Strong using what's called Moodle software. It's online learning software. And the training uses a mix of video, slides, visuals, and interactive test questions broken up into 5 modules. It's quite convenient. Instructors can complete it on their own time, anywhere that they have an internet connection. It'll save their progress. They can work on it for a while and come back to it and complete it. We found it's worked really well. Instructors rate it highly. They feel it's effective, they feel prepared, they feel it's engaging when they take it. For the specific at-home version of Fit and Strong, we've been training. These are people that are already trained in traditional Fit and Strong, and we've been meeting with them via Zoom for about a 60-minute meeting before they get started with the at-home version to go over safety considerations and logistics that are specific to the at-home version. We also hold a weekly debriefing meeting for all of our current at-home providers. And this is kind of like an open office hours meeting. Instructors and providers join. We provide TA related to Fit and Strong at home and answer any questions that they have. For Fit and Strong Plus, we can train instructors in a similar format as the at-home. We can meet with them via Zoom meeting. Again, these are mostly going to be people that are trained in traditional Fit and Strong, and we can train them in the Plus, the information specific to the Plus version via Zoom meeting. So we have found that, this hasn't been much of a barrier. Most of the people we work with, we're all kind of used to training and meeting and doing things in this format, and it's worked well.
Great, thank you, Drew. Paige, I'm going to pivot back to you, and then we'll go to Nick. And of course, again, please continue to type comments and questions in the chat box.
Oh, from Seattle, we were looking toward Chicago and wishing we had a remote delivery like Drew and Sue in those initial days. But we certainly, again, we've learned by example from our program administrator colleagues. We started with the Enhanced Wellness Program because that program, as I said, did not need to be paused, which meant we needed to train more people. So there were people coming over to be trained in the health coaching format because it was a great opportunity to, for even healthcare navigation, COVID question, health literacy navigation, et cetera. So we quickly moved to interactive video conference platform training, decreasing actually the amount of the training, but having smaller groups of people. So it's 2-day training, 4 hours a day with a lot of interactive skill building. Echoing what Drew said, we increased our opportunities to meet with folks and really have those debrief sessions with them, as well as practice and skill build together around motivational interviewing techniques. They're core tenets of that program. We had an improved, I see Nick there. Nick's hired for all of us to do marketing, Nick. If you need a second job, it sounds like yours is pretty big already, but we definitely had an improved ability to meet demand and a reduced cost to the delivery organization. Wasn't taking up as much staff time. There was no travel time to sites, to a common site for training, for instance. And we really felt as a team, and the feedback that we saw in the evaluation from trainees, we're able to do some deeper skill building and problem solving in these smaller group trainings that were teed up. So it's been feasible, it's been appropriate, it's gotten high satisfaction ratings. And right now we're taking that model and with the support of the ARP Foundation, building out a asynchronous model, similar to what Drew was talking about. Instead of Moodle, we're using the iSpring authoring software. And we're on track to move into focus group testing next month, so in August. So we're really excited about that work. For enhanced fitness, our work that started with enhanced wellness, we looked across the aisle and we saw what was going well there. So we did our first enhanced wellness trainings in May of 2020. And so by June, we had a similar interactive training set up and running for enhanced fitness. And we've been able to access trainers from around the country to actually engage and teach those trainings, remote trainings. So that's been really terrific. We've been doing a lot of training. We had an improved ability to meet demand. The amount of time was about the same. It was decreased just a little bit. One of the big changes was that there was a one-on-one teach back to a master trainer of a full class. Our master trainers really felt that that would be necessary to give them confidence that the remote training was preparing instructor candidates well. That has been so popular with both the instructor trainees and the master trainers. They just feel like people are really well prepared. They're getting just maybe a little bit more mentoring. So we will be continuing that format. We're probably doing, I don't know, 5, 6, 7, 8 trainings a month right now. There's a lot of people that, even if they're going back to in person, they may have had some instructors who haven't taught these classes in person in 15, 16, 17, 18 months. So they're wanting to refresh them on the protocols and send them back through training. So it is, it's a fire hose right now of training. Let's see, again, feasible, appropriate, high satisfaction from both trainers and trainees. Will we build that out to an asynchronous model? Well, we're going to learn from our enhanced wellness experience, and it sounds like from our Fit and Strong colleagues as well about doing that for enhanced fitness. So got a pen in that right now. So that's where we are.
Great, thank you, Paige. And Nick, can you bring us home?
I know we're running out of time, so to increase the number of people and number of leaders for the Walk with Ease program, we were very intentional to make the class exclusively available online. It's only available online. It's a 3-hour class. It's $89. It's available through AFA, which is a national fitness certification organization. To make the program accessible, we keep participant costs low. The book is $11.95 retail, $5 for all of our community-based program organizations. Reach out to me for a promo code. And we also reduce the administrative barriers that make evidence-based programs difficult to deliver. So the Arthritis Foundation will not require organizations to turn in waivers, co-sponsorship agreements, and attendance forms. That administration, I'm more than happy to provide technical assistance, and there's lots of information on how to run your program in our training materials, but I'm not going to run your programs for you. So we allow a lot of local control for those programs, and we're very, very happy to provide any technical assistance for our national and local partners to deliver those programs. So with that, we really hope to continue to grow the program. Thank you.
Great, thank you, Nick. And we are we're gonna wrap up here in the next 5 minutes, but wanted to make sure that we leave folks with additional resources from each of these programs. So I'm going to copy the links here and put them in the chat from each of the programs that we've heard from today. And of course, for those of you who would like to link directly from the presentation, I assume that that will be available as well following the webinar. And of course, you can always reach out to EBLC or any of our directors for additional information. So we do have about 5 minutes if anyone has any remaining questions, happy to field some of those. And I know Sana and the Sophie team have some closing remarks as well. So feel free to put any additional questions in the chat.
Yeah, thanks. Thanks, Autumn, and thank you to all of our speakers. One other thing I'm going to ask is that if speakers feel comfortable sharing their emails in the chat, so that if there are any participants who would like to follow up or they have some additional questions, that they have a contact email for you. And let me check.
Sorry, Sana, I just. And feel free to reach out to me as well. I can point you in the right direction for our EBLC leaders and subject matter experts as well.
Okay, and then with that, I just want to give a big thank you. So thank you all for providing your questions and actively participating in today's discussion. So if you enjoyed today's webinar and are interested in participating in an upcoming webinar, you can join us tomorrow at 1 p.m. To learn more about helping institutions of higher education prepare for fall 2021. And then if you enjoyed this webinar today, you may also like the following on-demand products. And while you browse our core catalog or content library, be sure to check out the top 5 journal self-studies of 2021. And if you missed it, we do have our Advocacy Summit from 2020 and our recent annual conference all on demand, and they're available in eLearn at course. You can visit our professional development page at sophie.org for more information on how to view them. And then once again, on behalf of Sophie, I would like to extend a large thank you to both our presenters and to all of our participants today. Thank you for bringing your unique perspective to today's webinar and being very interactive and engaging. And then if you are interested in more information and want to learn more about the arthritis series, I'm going to go ahead and drop the email. So you can just go ahead, email info@sophie.org and enter in the subject line arthritis interest, so we can make sure to follow up with you with additional resources and then also linking our YouTube page.
Great,
and then
thank you.
So sorry. Once again, today's webinar was recorded and is going to be archived within the next 48 hours at Sophie's eLearn page. And then please take a moment to complete the feedback survey following the webinar. And if you have any questions, you can contact info@sophie.org.
Wonderful. Thank you all. Thank you again to Sophie and of course to our speakers today. It's been a pleasure, and thank you all more importantly for the work you're doing in communities on behalf of older adults and people with disabilities.
Thank you all. Have a good
Thank you.
Thank you.
Thanks, everybody. Take care.